Good afternoon. I'm Swami Iyer. I'm with Dr. Rami Komrokji, who is from Lee Moffitt Cancer Center. He's here today to give his impressions of the best of SOHO in myelodysplastic syndromes. Rami, welcome.
Thank you very much. Good afternoon.
So Rami, you had a good session this afternoon. So tell us what you thought were very exciting. It looked like there were 4 presentations worth discussing, one by Dr. Valeria Santini. You had a presentation on Highrisk MDS, and then Dr. Yaroslav Masayevsky talked about all the next generation sequencing so deep that we have to still sort out those issues. And of course, you always have the eternal question of transplant. So in this day and age of MDS, what are the exciting developments?
Right. No, I think we really had an interesting session. And as you mentioned, I think we covered different aspects of the disease. We had also a wonderful debate about the role of combinations by Dr. Kaur and Dr. Karaway. I think to start with, Dr. Santini kind of set the stage for what's currently the standard of care in lower risk MDS patients. So she went through the data about use of erythroid stimulating agents. She discussed ways to better identify those patients that are responders. Then she discussed a little bit data on lenalidomide use in the lower risk. Obviously, we know about the deletion 5q, but she went also in details over the non-deletion 5q, a study that she recently led in lower risk MDS patients. And she also discussed a little bit about the role of the hypomethylating agents, azacitidine, decitabine, which we tend commonly to use in the United States, but they are less used in Europe, and their role is evolving how to be used or approved in Europe. So that was her part of talk.
Could I ask you a question about the low risk? So obviously the role of erythropoietin is, for the community physician, is very straightforward. And somebody is diagnosed with MDS and the bone marrow is done with refractory anemia, and you have certain levels of erythropoietin, you have a guaranteed response to some extent. So where do we stand with that, and how long to use? And with this data of lenalidomide, which is clear cut in 5q deletion, even in the non-5q, there's always this question of when to add or supplement the erythropoietin.
Right. So that's a very good question. I think they are still very acceptable first step. As you mentioned, if you select patients that are not heavily transfusion dependent, low serum EPO, your chances of response could be as high as 60 to 70%. Unselected, the chances of response are much less. And some of those responses are durable, actually. You could get out of them 18, 24-month duration of response. She showed some data today, even that in some responders, they may drive actually survival advantage. And it seems that also those patients that have a primary or secondary failure to ASAs don't have as good as outcome as we think. But to answer your question also, in a way, should we move other treatments earlier on? I think in deletion 5q, there is some debate. The NCCN guidelines, for example, in deletion 5q recommend going to lenalidomide directly. In Europe, you start still with ESA, then go to lenalidomide. The argument for that's how the MDS 003 and 004 studies were done. However, the response rates to ESA and del5q are low, so we may make the argument to skip that and go to lenalidomide. In the non-deletion 5q, actually, there is emerging data on the combination of ESA and lenalidomide. We've done a study in the past looking at monotherapy failure for each of them, and when we combined the 2 agents, we had a response. The French group had presented preliminary data on a randomized clinical study comparing lenalidomide alone versus lenalidomide ESA in the non-deletion 5q, and they showed higher responses for the combination. And there is intergroup study in the United States that's ongoing and short of finishing accrual that hopefully will answer that question.
So and it's great to have this, but again, coming back to what clinical determinants, obviously this is something you would recommend for the community physician to do in the context of a clinical study, or is it something that are there any clinical guidelines?
For the combination strategy. So I think obviously if there is access to clinical trial, that's obviously the desired way, because we can learn more with that. In absence of clinical trial, I think for patients that had no response to ESAs and are moving to next step, lenalidomide in non-deletion 5q really should be selected for patients that are purely anemic. And in those patients, one could reasonably try the combination of ESA lenalidomide to see if the response rates are going to be higher, or start with lenalidomide monotherapy for a couple of months and maybe try the combination later on. Again, however, then whenever there is a clinical trial, probably that's desirable. I still think it's very reasonable to start with ESAs as first line and then move to the other options down the road.
Excellent. So how about the high-risk MDS? Right. That is your presentation.
Right. So I think similar to the lower risk, I try to give overview of the current landscape of management. I think both myself and Dr. Santini also touched base also on the risk stratification for those patients, because that's been an evolving story in MDS, and there are several new risk models, including a revised version of the IPSS, International Prognostic Scoring System, where we could really upstage many of the patients that we used to call lower risk, or we know that those patients will not do as well. And then there is also the integration of the new data from the next gene sequencing on somatic gene mutations and their impact on outcome and tailoring therapy. So in reality, in higher risk MDS, currently the allogeneic stem cell transplant remains the only curative option. Although we've got better, we could transplant patients up to the age of 75. Still only 10 to 15% of MDS patients will get allogeneic transplant, so the majority will not. And the decision of allogeneic transplant, in my opinion, should be individualized with the patients, discussions of the benefits and the risks. Definitely younger patients should be considered always for transplant. Older patients in their 70s, I think they have to understand the pros and cons. But as also Dr. Ansati later discussed, we look at the disease itself, but we also look at the age, functional status, and the comorbidities for patients. And all of those play an important role in defining patients that go to transplant. An emerging role also is for those somatic mutations, particularly the P53 story. If those patients have a detectable mutation after transplant, the coming data suggests that they will not do as well. And perhaps those patients should go on clinical protocols when they are transplanted, maintenance strategies. So for majority of the patients, hypomethylating agents, azacitidine, decitabine remain the standard of care. I think we need to maximize the benefit of those treatments, how to use them. So I discussed briefly a little bit how to assess response, and that sometimes a stable disease could be an acceptable endpoint in those patients. And maybe now with more molecular data coming, we could identify patients that will have higher response to hypomethylating agents, that in those patients, actually, if those responses are durable, one could argue maybe we can delay the transplant even later on. There is definitely an unmet need to treat those patients with complex karyotype P53 mutation.
So if you would say that if there are 3 or 4 things that would allow you to choose a transplant candidate right up front, obviously age, the younger the patient, and maybe the Cutler model, the higher the risk status, the Charlson's comorbidity index, maybe the morbidity, and the P53 and the molecular status. So those 4 things would be reasonable options for anybody to consider.
Right. I think the general thing is, obviously at this point, this is the only curative option. So we always should think of transplant for older patients. And it's exactly going through this. You are referring to the Markovian decision model that showed actually the maximum gain in survival in patients in higher risk MDS is to go to transplant directly. And the reason for that, although the cure rates could be higher in lower risk disease, if you transplant patients that have less blast, better cytogenetics, the cure rates are higher. But you cannot justify a 20% transplant-related mortality in a lower risk MDS patient that had many years to survive, or the expected survival is measured in years. While in higher risk, when you are estimating somebody's survival 1 to 2 years, I think you can justify a 20% transplant-related mortality, and the gain in survival comes best if you proceed directly. I think there is a lot for us to learn about what we do prior to transplant, do treatments with hypomethylating agents, other agents prior to transplant, change, benefit if we take somebody to transplant with less blasts, complete cytogenetic response on treatment, are they going to do better, role of maintenance post-transplant. So the disease itself definitely is one item. Then, as you mentioned, the patient, the host-related factors, which is probably interplay between age, and functional status and comorbidities. I think the question is age, is not whether the patients can go to transplant or not, because the data shows that they benefit, but it's really what's expected survival advantage. So I usually would discuss with somebody who's 50, I say without MDS you're expected to live to age of 80. And with MDS, the survival is limited to 2 years, so you have a 30 years to gain. Somebody who's 74, 75, the estimated survival for somebody for patients without MDS, a normal population, is like to 80. So the gain of survival becomes limited, and I think those decisions are individualized with the patients, how aggressive they want to be and how much they want to get, to trade the quality of life, the intensity of transplant versus a couple of years gained in survival as they get older in age.
So I guess once the transplant candidate, it's easy to move them along. But for a vast majority of the patients, you are doing 5-azacitidine. And the big question comes, you have the survival data, and that being said, Dr. Fenno's survival data curve. Having said that, there was also this very intriguing presentation from Dr. Masiewski and Aziz Naza showing that you can actually pick patients very early on who can respond to the 5-aza and the decitabine-like regimens, because we don't want to subject them to this prolonged hypermethylating agent. Obviously, the flip side is that once they do fail, you don't have anything else out there.
Absolutely. So I think we are learning about that, and as also alluded by Dr. Masiewski, it's not really a straight question. Those mutations, we lump them together, but in reality they are heterogeneous. There could be a missense, nonsense mutation that the responses are different. We've been kind of simple in the way we look at this, but there is definitely markers that seem to predict response. In my mind, obviously there are a couple of ways we can use this. Is obviously you are selecting patients that have higher response, like as I mentioned even in my discussion, the paper by Dr. Behar looked at patients that have a TET2 mutation with a allele burden of more than 10%, wild type SXL mutation. Those patients had like 3-fold chance of response to hypomethylators. Also what was presented by Dr. Nazha today, if they have a favorable profile, they could have a 90% chance of response. The sad reality is we don't have other options. So there is always that 30 to 40% chance of response, even in those patients that don't have that molecular profile. So one strategy will be, okay, I'm gonna target those patients with clinical trials, or those are the ones that maybe we should try to strive more with combinations in. The other way is what I was also talking about, or like trying to get the idea of if we know that those patients that have this molecular profile, favorable molecular profile, have durable responses to the hypomethylating agents, maybe we can start also questioning the timing of transplant in those patients. So if I know from a certain molecular profile that this patient has 75% chance of response, and that response is going to be 2 to 3 years, that equation on when should we transplant the patients could actually be different.
Excellent. So, and obviously, what are you excited about the newer agents out there?
So I think as was mentioned through the day, there is obviously excitement in the whole field about the checkpoint inhibitors, the PD-L1, PD-1 inhibitors. They are being tested in heme malignancies. Again, there are concerns whether they, counterintuitive to use or not, but it's definitely interesting to use them. Our group had been interested really to try to target that population with P53 mutation. I think that's an unmet need. We have one drug that we are testing, so we are excited about starting the study with this molecule AP4R256 that we are going to do in combination with hypomethylating agents. So again, as the debate today, I think the combinations are not dead. I think it's finding the sequential way or the appropriate way of doing them, maybe targeting certain population based on molecular profiling. In the lower risk MDS, I think the TGF-beta inhibitors targeting the microenvironment is a very exciting strategy. There are several trials ongoing trying to look at the targeting inflammatory aspect of MDS, TGF-beta pathway with some very promising results.
Excellent. And yes, while we have all this excitement, there was this very nice presentation by one of your fellows, Dr. Haider, on trying to revisit the immunosuppression strategy, and based on Dr. Alan List's data goes all the way back to Jeff Moldman's and then NIH work. Right. So one of the questions that I was asked is why we should not give up on that, and how do we choose patients to go on those types of therapies?
Right, and I think that was the reason why we actually looked into the project, because in our place we use them in reasonable number of patients. You saw like we had at least 66 patients over years we treated. They are underutilized, as Dr. List also mentioned today in the meeting, because of worry about the toxicity side effects. Those typically are not done in community hospitals. Tertiary centers do the ATG. And there is this thinking in general, when the ATG started to be used, they were used in patients that have hypocellular, hypoplastic MDS, close to aplastic anemia, which made sense. So the general impression is that's the selected population where they work. And as you know, hypoplastic MDS is only 10 to 20% of the cases, so their use have been limited. In our experience, as you saw from the presentation today, actually, the predictive factors of response are probably mostly most important is when they are administered early on the disease, which makes sense because there is a lot of immune dearrangements. As the disease continues to progress, I think there is clonal evolution, and maybe the role of immune dearrangement is not as important. So being used early in the disease, obviously by prior studies, age, younger patients, which again suggests more immune dearrangement pathogenesis in the disease, HLA DR15 status. So I think the NCCN guidelines actually endorse use immunosuppressive therapy, and they put those patients that have probability of response. But to your point, they've not been widely adopted, and that's why we were trying to bring this back and underscore that this is underutilized treatment. So
I think that is very well done, because I think in addition to what you mentioned, if you look at 3 other factors, hypoplastic MDS, the age, and HLA-DR15, and perhaps even looking at LGL clones. Right. If you see an LGL clone, you suspect there's a T cell population trying to attack the bone marrow cells. And yes, there might be somatic mutations, as Dr. Maciejewski showed, in those patients, but the immune strategy might be more meaningful, and in addition to cyclosporin.
Absolutely.
So this is a very good time for MDS. Don't you agree? We've been doing this for a long time now, and there's been so much excitement from the debate that was generated, and though the question that was asked is combination is not as good as single agent 5-ASA, but I think we have a lot to look forward to. Right. So if I may summarize what you've just said from the presentations, I think there's a lot of evolution in the therapies, in the biology, in the molecular markers, and obviously we're looking for the right combination and the right sequence with 5-ASA, so that for those vast majority of patients who cannot get a transplant, you can provide meaningful outcomes. And for those who are transplant candidates, obviously you want to push them in the right direction, but don't forget the use of immune suppression in these patients. Absolutely,
I totally agree. I think the explosion in knowledge has been amazing. What we learned about the biology of the disease, the mutations, had really completely changed the field. And given that MDS was one of the first diseases where people started exploring this, we really have accumulated now a good amount of knowledge. I think the frustration for clinicians like you and me is sometimes we still have patients in the clinic. We wanted to get those trials for them as soon as possible. We want to have several options, because sadly, as Dr. Gore said, our patients sometimes are still unfortunately dying from this disease. We want to optimize the transplant. We want to get better combinations. The azacitidine was a landmark improvement in survival, but today it's probably not enough for somebody has passion for this disease and improving the outcome. We definitely need to do better, and this is the right time, because now I think we learned the lessons that combinations and future therapy should really be based on the biology and our understanding, which had been enhanced enormously in the past few years. So
excellent. On that note, I would like to end by saying participate in clinical studies which looks at biology or treatments. And Dr. Komrokji, I thank you very much for this very useful summary of the MDS presentation with the best of SOHO. Thank you once again.
Thank you very much. I appreciate it. Thank you.